Welcome, everyone. My name is Shirley, and I will be your moderator this evening. I am excited to welcome Dr. Dimple Desai as our speaker this evening, a practicing dentist and leading expert in direct bonding and advanced adhesion techniques, as she shares her criteria for composite selection. Before we get started, I just want to take a moment to go over some housekeeping. If you have a question, please type it in the Q&A section and we will answer questions live at the end of the presentation. And please note that CE is not available for tonight's webinar. With that, Dr. Desai, welcome and thank you for being with us tonight. I will pass it over to you now.
Thank you. Thank you for the introduction. So thank you for having me tonight. I'm going to be going over aesthetic and functional bonding, minimal to maximum bonding results. So I'm going to be covering a lot of anterior composite bonding and touch on some posterior composite bonding. A lot of the techniques that I personally use and do on my own patients is what I'm going to demonstrate and show. So without further ado, let's get into it. So a little bit about myself before we get into my presentation. A big motto that I live by is do what you can with what you have where you are. I was fortunate enough in 2019 to start my own Luminous Smiles Foundation in India, the picture on the left that you can see. Unfortunately, I wasn't able to go back the subsequent year just because of COVID and haven't been able to return. But I had the privilege with my family to go to India and distribute their oral hygiene, some of their first oral hygiene aids like floss, toothbrushes, toothpaste, in addition, doing some oral exams. And I can't tell you how touching and heartfelt it was. And we went to 2 different orphanages. One of them was a deaf, mute, and blind orphanage. And this one with the picture on the left was an orphanage where it was in a little small village where parents, had dropped off their kids, no questions asked. And this really nice facility was raising the kids and teaching them just basic ABCs of school. In addition to that, I've been fortunate to publish a few articles. A lot of them are about composite bonding and sharing my techniques. Some of them about veneers and how I do veneers. In addition, I was also named a 40 under 40 back a long time ago. That's passed since then. So now let's get into tonight's program. I'm going to touch on 4 main components. So the first is going to be functional alignment and occlusion, getting the teeth into the correct position before we even do any sort of bonding technique. 2 is what are some indications and contraindications for composite bonding? 3, how do we prepare these teeth for composite, aesthetic bonding, and functional? When I say functional, I mean a lot about posterior teeth and its functional use. Aesthetics, a lot of it with anterior teeth. And lastly, once we prepare the teeth and deliver this beautiful case, what do we tell our patients? What's our post-composite bonding instructions with the patient? So first, number 1. To me, the most important thing is functional alignment and occlusion. I always say there's no point of building a Taj Mahal if we don't have the correct foundation in play. A lot of the anterior chipping that we're seeing, the posterior wear, a lot of it's due to occlusion. Actually, my patient I just saw this afternoon chipped a beautiful crown on the occlusion and he couldn't understand why. It's just because his occlusion was off balance and he wasn't articulated correctly. So once I explained that to him, we can now proceed with doing the crown and have a longevity of a crown. And same applies with bonding techniques as well. So checking posterior contacts is important. And I really stress having simultaneous contact in the posterior. What do I mean by that? So you want to have the right and left sides of your mouth balanced and have simultaneous occlusion. And at the same time, a lot of that holdup can occur if there isn't simultaneous occlusion due to anterior interference. So we got to remove that. How do we remove it? Let's get the teeth in the back in the correct position and move these anterior interferences out of the way. I love this picture that I've placed here, and it's actually taken from the Coy's manual. And the first picture is a frontal view of our chewing pattern. And the second picture is a profile view of our chewing pattern. And most of the time, this is how I explain things to my patients, is that we don't chomp like alligators. We chew in an envelope. And I feel like that picture says it all. So when we're chewing in this envelope, we have to make sure that whatever the interference may be when our mandible's coming out, that we remove it. That way we're not continuously having this habitual pattern of chipping. And I know we learned a little, I feel like when I went to dental school, we barely touched on occlusion, and I appreciate it so much more now. And it's the basis of my practice and how I do my procedures. So first and foremost is obviously occlusion. So let me get into some orthodontic scans and some patients that I've done, just to kind of demonstrate what we're presented with from the get-go and how we can alleviate these anterior interferences thereafter. So you can see this first picture on the left is a pre-ortho scan. And, you know, the red dots just show you where the anterior interferences are. This patient came to me with a really deep bite. Unfortunately, you can't see in this picture, but you can see how her maxillary anterior teeth are retroclined. And so subsequently her lower anterior teeth are following. And so she was a young gal. She had a lot of chipping on her anterior teeth. And I explained the occlusion pattern, what she was doing. And so on the right, you can see her post-ortho scans. And she was in orthodontic treatment for about 20 weeks with Invisalign. And I think those results are pretty marvelous. Obviously, she was very compliant. And once we put her teeth back into the correct position, and what I mean by that is removing all those red dots, anterior interferences. So the maxillary anterior teeth were flared out slightly, and the lower anterior teeth were intruded, and there was minimal contact with those 4 teeth. And in this case, with this patient, we ended up doing 2 very minimal prep veneers at the end to address her anterior chipping. Another orthodontic image I want to show you is this patient's actually a dentist, and she chipped number 8 pretty severely. And she didn't know why. She said, hey, you know, I've seen some of your bonding. I want to get bonding done. And I said, hold on, let's back it up a second. So I showed her the slides. I showed her what her interference was. So we repositioned her teeth again into the correct position. You can see number 10 is overlapping. I mean, she's almost div 2. And so we put that back into position the best way we could with clear aligner therapy. Moved out number 8 and 9 to the correct position, and subsequently the lower teeth as well. So that way we have a nice occlusion. And she herself even said, my bite feels so much better. I feel I can hit on my back teeth a lot better. And then we ended up bonding number 8 after that. And lastly, this is another patient that I saw. Again, you can kind of see he's got a lot of wear on number 8, 9, and some on 7 and 10 lingual, and it's shown with the red dots. And of course, his lower arch is going to correspond, and those teeth are going to correspond because teeth want to touch. And so once he too also said, hey, I just want to do a little minimal bonding. Just my teeth are becoming really transparent, and it really bothers me. Same thing. I said, hold on a second. Let's first figure out how we got to this point before we move on to address the aesthetic concerns. And we put him through Invisalign. And again, he has some pretty beautiful results at the end. And then we were able to bond onto the lingual. This is the post-ortho scan is prior to bonding. That's why you could still see the wear. So again, I cannot stress it enough that occlusion is everything, especially these days, and just knowing it very well, and to the success of bonding. So let's touch on some posterior teeth. Once I align the teeth, another big mantra I live by is that I am not here to over prepare teeth. So if I can align the teeth into the correct position, get the function correct, Then we can go on to whatever aesthetics are needed, whether it be bonding or ceramics, and that can lead to minimal preparation with ceramics and no preparation with bonding, which I'll show you later. And with the posterior teeth, a lot of the times, if I see that there's some sort of issue where teeth are not occluding correctly, like this patient with the image on the upper right, not only did he have decay, but he had a little dimpling effect on the cusp tips. And all I did, in addition to just doing his fillings, on the lower left, you can see I just added a little bit of composite. That way he has a nice contact point on number 19 and 18. I'm very big, again, into simultaneous occlusal contact. And so I just created these pinpoint contacts. So you don't want your contact too broad, because then you can have some slipping and sliding. But at least he's getting contact and we can prevent any further wear. Because we all know once he's dimpled out this teeth, these surfaces, it's going to move on to another. So let's try to prevent that. And composite's just a beautiful material, so we can, maneuver it around and add a little bit. And if it's too heavy, we can take it away. So I'm a big fan of that. So let's get into some indications, contraindications for composite bonding, specifically posterior teeth. For me, my indications are, obviously it's a more conservative approach. You can control it a lot better. And like I just said, you can add to it. And if there's too much, you can just polish it away and get the correct occlusion that you need, whether it be for occlusion or even just aesthetics. It's less invasive. We all know that. And you get instant results, and the ease of adjustments for us, I don't think you can get any easier than that. You're not dependent on anybody. You can just do it yourself. Contraindications, I do not do composites over large surface areas. Obviously, we all know the shrinkage factor. I just don't feel comfortable doing it. So if that's the case, I may move on to porcelain. But again, I explain this to my patients. That way they're aware and they understand my philosophy as to why I choose different materials. If you're not knowledgeable with bonding protocol or have the experience, then I can't stress enough that you need to make sure that you have it down well. My assistants know we time every single procedure. So I was taught under Pascal Monnier, and I still follow his protocols to this day. So I'm timing the etch, and I literally tell them, okay, ready, go. Rinsing it thoroughly for another 20-30 seconds. Only drying the enamel, keeping the dentin nice and moist and wet. And whether you use a total etch technique or self etch, I'm scrubbing that bond in for at least 20 seconds, air drying for 5, and curing it. These are just continuous patterns and repetitions I use on a daily basis. And of course, the biggest component is isolation. So if you're not able to isolate, your area is wet, dirty, it's bloody, we're not going to get the success with bonding that we desire. So you got to make sure, if you want to use a rubber dam, if you want to use an Optricate by Ivoclar, simple cotton rolls and gauze and a great assistant, whatever your technique is, just make sure you have the ultimate isolation. Preparation. So I wanted to show you this picture and show you on the posterior teeth how minimal my prep is for this tooth. This is actually the same tooth that I showed earlier with the dimpling that had occurred on the occlusal surface. So really just removing whatever decay is needed. And that's the beauty with composite. I was taught to do amalgams in school, and we're fortunate that we did have Pascal Monnier teaching us his first year at USC. And I felt like I learned composites in the correct manner. So I knew the techniques and I knew how to bond correctly from the get-go. But I learned how to do amalgam and, doing retention grooves, and it's all about the mechanical way of making sure your amalgam doesn't dislodge and all this stuff. So when I switched over to composites completely, this is a game changer. It's easy. You just remove what's needed, make sure nothing's sharp, and again, have your protocols in place, and boom, you're done. So for anterior teeth, this is a patient, the picture on the right is showing you post-Invisalign treatment. And after, you get these teeth into the perfect position, I always tell my patients, I've created monsters because they're like, well, doc, everything looks good, but what are we going to do about these chips? Because now the teeth look great in their position, but little nuances will bother them. And so I outlined in white right there is how I bevel anterior teeth. So I do a starburst bevel pattern, which we'll go into later. That way we can really blend the composite in well, and you don't see the margin or any discrepancy between the tooth structure and where your composite is. So what's my bonding armamentarium? So let's talk about bonds for a bit. Like I mentioned earlier, you can do a total edge technique. There's various brands out there for total edge technique. So, you know, that involves obviously an etchant, 35 to 37% phosphoric acid. And if it's an enamel, you want to etch for about 20 seconds, 15 to 20 seconds. Dentin, not, you know, I think it's about 10 seconds, but I don't use total etch these days because I'm really happy with the self-etch technique. And then again, rinse and dry. You want to dry your enamel, but keep the dentin moist. Apply the primer to the dentin. So specifically scrub the dentin. So that way you revive those collagen fibers, dry and place the bond, and then cure it. With self-etch, I've had great success. I don't get post-op sensitivity, again, because you want to get your protocol down really well. So I don't even have my assistant start the timer until I have the etch around, and then I say go, and then they start the timer. But I've had great success, and I'm a big fan of those bonds. On the left is adhes, that picture, which is self-etch. Bisco, all bond universal. Voco is great as well because they have the ease of dispensing, no contaminants, and of course 3M, the Scotch. So what do we use? What's our bonding armamentarium? Composite selection. There are loads of composites out there. I can tell you for myself in my own practice, I have a dispensary of composites. And I try to teach my assistants, okay, well, we're going to use this composite for this and that composite for that. But I have loads of shades and various brands, and I like to dabble in all of them. So compules, obviously, I like using compules as my go-to. They're easy to dispense. You don't have that much contamination. You minimize the air bubbles. You know, that picture on the left is the CompoJect by Clinician's Choice. I like to call it the Rolls Royce of CompoJects. It's just because it's very easy and it fits really well in your hand ergonomically. And you can use tubes. However, you know, you need a dispensing station. I say that because I'm a really big OCD person, into where I don't want to dispense it with an instrument straight onto a rubber glove because the glove could be contaminated. So when I say station, I'm thinking a glass slab, a clean glass slab, and you know, you can make little sausage rolls if you want. You can minimize waste with it just because you're just taking out what's needed. I really don't use tubes too often because I'm into the compules because it's just a lot easier for me. In terms of shades, like I said, I have a dispensary of composites and tons of shades. So I like to play around with shades. I'm in Newport Beach, so I can tell you right now, A2 or 1M2 is not my patient's favorite shade. So I use a lot of brighter shades in my practice. Now, if I want to get a little fancy and add a little dentin or do a little tint in it, then that's one thing. But most of the time, my patients desire nice, clean composite fills. And incremental composite versus bulk fill. So what do I mean by that? So the Admira Fusion by Voco, they have a bulk fill where you can, if for deeper boxes, you can do 4 millimeters before curing, or you can use a 2 millimeter incremental fill. Just depends. I take my time with composites. I'm not in a rush. I always say class 2 composites take me the longest time, especially if you have a deep margin. So up to you how you desire to dispense your composite. If you're kind of into just, hey, let me just squeeze it in, get the box done, 4 millimeters, then cure, that's up to you. Or if you want to incrementally fill the box, then 2 millimeters is a good one. So what is my pre-bonding prep? lately, and most of the time, I'm going to use an air abrader with aluminum oxide, and it's 27 microns at 40 psi. And I like to air abrade because it really gets rid of all the debris onto the tooth surface, and you feel like you're starting with a clean palate. Thereafter, I'll rinse, and then I'll use phosphoric etch for about 20 seconds on the enamel, and then rinse. And if it's again an enamel, I'll dry it really well, give it a nice frosty appearance. Dentin, you want to keep it moist. And I like to use the self-etch bonding, scrub it in for about 20 seconds, air dry it, and cure it. So I wanted to show you my technique on a typodont. So on the left is my packing technique, and you can kind of see how I do it. I kind of flash the timer as well because I'm really big into timing. And I'm scrubbing it, air drying it. And the ring I'm using is the Dual Force by Clinician's Choice, and I'm using the Admira Fusion composite and bulk filling it. It was a deep box, so I'm bulk filling it. In addition, if you saw, I mean, the video will replay. You see these instruments I'm using to pack. I can't live without my Optroscope instrument. So that's by Ivoclar, and it's a really nice instrument to really pack in there. And they have various shapes. And so that's really what I use for class 2s. And in addition, if I need to do some sort of functional bonding on the tooth surface, if again, for occlusion reasons, then I'll use the same instrument. Once that's completed, I'm moving on to polishing. And the Admira Fusion is very nice because it polishes pretty well. It's similar to Omnichroma, where it blends with the tooth structure really well. And whenever I polish, we're going to get into articulating papers, but I'll obviously check where they're occluding. And I like to do pinpoint contact, so I'm going to keep my cusp tips nice and sharp and create a nice fossa for the opposing. So I like to use the football red fine burr, and then I'll use the nice occlusal brush just to polish things up. So let's get into some fun stuff with indications and contraindications for anterior composite bonding. So the benefits of it, you have complete control over the aesthetics and outcome. I have been doing a lot of anterior composite bonding these days because I have control issues and I like to control my case. So we'll get into it again a little bit later, but if I can contour the teeth the way I want to for the patient and see how it looks in the patient's mouth with their aesthetics, with their lips, with their full face, then I'm not dependent on a ceramic to do what I envision in my head. So that's really the number one reason for me, is that I can control the factor. And say if we create a nice anterior edge and the patient's like, oh, I want it a little bit shorter, it's so easy just to polish it and bring it to the length that they want to immediately. Another great thing is you don't have to drill. I feel as though patients are smart these days and they're looking on social media and they're seeing that, you know, sometimes you'll see a patient with teeth like this and then they end up like this, the before and after, and they don't see what happens in between. But those who dive in deeper will see, oh, I don't want my teeth to turn into little pegs. So rest assured, there's minimal drilling or no drilling at all in my case, and patient feels at ease. And with no drilling, you don't have to really numb the patient. So it's great. Again, you see instant results and the ease of adjustments. I can't stress any further. You know, what I'll do is after anterior composite bonding, I'll show the patient, say, hey, what do you think of the length? How do you like it? And if they say, oh, just a little bit shorter, because, you know, initially when patients see longer teeth, it's a shock. Oh, this is a little long. And so I'll say, okay, you could sit on it, or my opinion is let's shorten this a little bit, and that might make you feel better. And it's just easy. The lab fees, I mean, whew, that's a benefit right there. You are the lab. You just have the fees for your composite, chair time, and that's it. It's easy. Contraindications. I say contra and also the requirements needed for successful bonding. And I just saw that I have a typo in requirements. Oh, my bad. Sorry. One, it's very technique sensitive and experience savvy. I can't tell you how many composite courses I've taken from Legends, at Cosmedent, at the AACD. I've just continually invested in learning how to do proper composite techniques. In fact, during COVID, because we all had to shut our practices down for 2 months, I created a whole lab in my dining room and took it over with my own waxing unit that I bought off of eBay, an electric drill that I also bought off of eBay, and all I did all day was just composite bonding. And that time I was still in the accreditation process, and so that really helped build up my speed and get my techniques down correctly and see where I wanted my line angles, my contours. So again, experience and just being technique sensitive for sure. Larger surface areas with color changes or shapes, and I put a question mark there. So I did that because I think that goes hand in hand with number one, technique sensitive and experience savvy. I feel comfortable to make a peg lateral into a nice, beautiful, regular shaped lateral. But others may argue and disclose that, no, it's going to stain over time, or it's not the good thing to do. You should do ceramics. But if you're comfortable with it and you get great results with it, why not? In fact, I have a young high school student who's going to come in after orthodontic treatment with peg laterals. And because of his age, I'm not comfortable with doing ceramics yet. So I explained to his mother, why don't we do nice composite bonding? And if and when in the future he wants to change it out and he's working on his own, then I'll be around to change it. But you can get beautiful results with composite bonding. And lastly, every step matters, from the placement to the packing, to the contouring, to the polishing. I think that if you get step 1 down really, really well, then the ease of moving into step 2, 3, and 4 thereafter is done really nicely. There's no rush with bonding. Do the right thing. Don't cut corners, and start it really well and just complete it really well. Okay, so let's get into some anterior images. Preparation. So I briefly shared in a previous slide how I prepare the anterior composite. So in this slide, you see the before on top. And like I said, I like to create a bevel. So I'll do a starburst pattern bevel, and it just really deflects the light on the teeth. That way, when you're adding the composite, you can't see where the margin is or distinguish the blend of the shades. So that's my go-to. I do a starburst bevel pattern. So that's depicted in the white. I'll etch beyond that. So that's the blue with phosphoric etch. And then once I dry it really well, it's a frosty white appearance. I'm going to bond and just be slightly shy of where the etch is. So that's depicted in the yellow. And you can see the results on the bottom. I mean, I'm pretty happy with that. She was ecstatic, and it just made her front 2 teeth just look very symmetrical. So with anterior composite bonding, my armamentarium. So I look for a few things specifically for anteriors. Consistency. I like a very creamy, malleable, easy to manipulate type of composite. I don't like it too hard when I'm doing anterior composites, because I'm spending a lot of time manipulating the composites, making sure that there's no air bubbles and getting it to the right shape. Like I said, you want to make sure you're packing it and placing it really nicely. I don't overload the tooth, just because if I want to add layers, I'm going to incrementally do it. So that's important to me, which is just the ease of manipulation of it. Now, shades. Prior to starting any sort of anterior composite bonding, I'm going to select the shade. And prior to any dehydration of the teeth, because we all know the longer their mouth is open, we're blowing air, the tooth is going to become dehydrated. It's a very false reading of the shades that you want to select during the bonding. So what I'll do is I'll either take a polarized picture of the teeth with my digital SLR, or I'll use something called Smile Light, which is the picture on the right below. And it's pretty cool because it's a polarized filter. So I'll place little balls of composite shades that I think that I like. I do only layering with anterior composites. I've never just done one layer. And so I'll pick the different shades I want. And then I'll either use the Smile Light to show me how it looks, or I'll take a polarized image with my digital SLR. Tints are a go-to. Cosmedent has beautiful tints that they make. And so I always have a nice glass slab next to me, and I feel like I'm painting a picture. So I'll select different tints based off of the adjacent teeth. If we're doing more teeth, obviously I have more wiggle room, but if I'm doing a few teeth, then I'm going to pick what's happening with the adjacent teeth. There's fluorosis, or if they're younger, they have more translucency, I'm going to pick a gray or violet tint. With fluorosis, I'll do, little patches of the white tint. So that image in the background is a little palette of all my tints. And again, I always use the adjacent teeth as my guide prior to any sort of dehydration. So while my assistant's setting up, I'm getting everything ready in the mouth and picking my shades. So going back to composite dispension. So again, I'm using compules just for the same reasons, the ease of it, lack of contamination, and minimizing air bubbles. In the background, you'll see Voco's composite instrument. That's pretty good too. I like that one. It fits in your hand really well. So, and it's easy to use. And whenever I'm using composites, I always make sure that I'm dispensing really close to the tooth to minimize all the air bubbles. Tubes, say if I'm doing finger-like projections, or if I'm layering in between the lobes, then what I'll do is maybe grab a tube, roll it out into little sausages, and place them in a glass slab. That way I can just kind of pick it up and add it directly to the tooth. So that's when tubes are good. But like I told you, most of the time I'm using compules. Consistency, again, that's everything to me. So can't stress that enough. So what instruments do I use and not use? So believe it or not, all those instruments that are on the image on the left, I love every single one of them, and I'm using them. I use different instruments to manipulate around different contours of the teeth, and which edge I'm going to use and which position I'm in. I'm pretty much all over the patient just to make sure that I can get the composite in the right place, and I can see from all angles and not just from one sitting angle. So I'm using my mirror at the occlusal view, profile view. You don't want to overbulk, underbulk, making sure the contours are correct. So I have a lot of packing instruments, and I specifically use just these instruments for anterior composites, and I have a whole cart for anterior composites. So that way I'm not messing these instruments with my posterior instruments, or, combining them. In terms of contouring, I'm a big discer. I love my discs. So this is an array of discs. So this is 3M, Meisinger, Cosmedent, and Clinician's Choice. And each one has its benefits, and there's different sizes. So it just depends which area I'm in, what line angle I'm trying to create, how big the surface area is. And I'll choose dependent on that. And of course, they're going to go from coarse to medium coarse, fine to super fine. And I'll go through the whole array of it. That way our results are looking nice at the end. Thereafter, I'm going to use the polishing slow speed ASAP polishers, and this really nice fuzzy wheel that I love to use with some Schein, or even Cosmedent has a great enamel paste just to polish it up. So how do I do this? Let's talk about that. So this is a step-by-step picture we're going to go through. So like I said, step one, I'm going to create a nice starburst bevel pattern. And so you can kind of see it on number 9, and just breaking it up. And I'm going to use a red fine burr just to create it. And because of all the debris on the teeth thereafter, number 2, I'm going to air braid it, get rid of all that debris so I can have a nice clean tooth structure. I am so OCD that I'll always change my gloves out too, because I can't stand that fine particle matter on my gloves, and I feel like it's going to contaminate my composite. So I'll switch out gloves, or I'll tell my assistant, get an alcohol pad and we'll wipe everything down really nice and clean. And then obviously rinse and dry that. And then we'll move on to step 3, where I'm etching. And if you remember the picture I posted earlier, I'm going to etch beyond the starburst pattern. And then with the bonding agent, just a little shy of that. Now, packing the composite. So I actually do my own wax up still diagnostically. So if I have a patient who's coming in for anterior composite bonding, I'm going to take a mold of their teeth and I'm going to do the wax up myself. And this is a little old school, but I like to do it because if I run into any issues in the mouth, I'm not surprised when I'm doing it on the wax up, and I know which angles I need to concentrate. I know what teeth might be a little bit difficult because of its angulation. So it's easy for me to be aware of it and acknowledge it before I even get into the mouth. So what you see in picture number 5 is an impression, a putty matrix taken by template by clinician's choice of my diagnostic wax up. So I waxed it up to the correct length that I wanted the teeth. And in this case, there was a diastema and it was post-Invisalign. So she wanted to correct diastema in addition to lengthen 8 and 9, just a little bit because her teeth were all very square and straight and the same length. And so once I pack in that composite, I'm going to place it into the mouth. And you can see in picture number 6 that I position it into its place. I create a little thin lingual shelf with the cleavage up against the teeth. And I'm going to keep it thin because, again, I'm going to layer. I'm not going to just pick one shade. And so I double check it, make sure it's good, and then we cure it. Thereafter starts my layering technique. So you can see number 7, how closely I dispense the composite to minimize the air bubbles, how creamy it is. And once I place it in the middle, I'll spread it out. And then I can develop my lobes from there, add my tint and whatnot, depending on what the adjacent teeth look like and what the patient also desires to. Because sometimes they don't want too much tint or they don't want to make it look like gray translucency. And then I'll smooth it out with a nice Cosmodent brush with some resin blend by clinician's choice. And this works really well just to smooth anything out and making sure everything's in place. And again, I'm looking at this from an occlusal view, from a profile view, from a frontal view, just to make sure that my tooth is not overbulked or under. And you have to keep that in mind, especially when you're layering. That way, whatever layers you're putting on, they're not too thick that by the time you have to polish or contour, you're not removing everything that you just did. Now, contouring, like I said, I love my discs. So I draw pencil marks all over my teeth. That way I know where I want the angles, what I want the tooth to look like. I am a line angle queen. I just love to look at perfect line angles. So I have to make sure they're perfectly symmetrical. And so I position the disc the way I want to, whatever way I need to, whether it's facing up or down. That way I can contour it correctly. Thereafter, once I get my angles down and go through the series from coarse to medium, coarse, fine to super fine, I'm going to go in with my polishers and start using some textures and adding some nice little nuances to the tooth. And then using a polisher just to polish it up a little bit more with some paste. Once that's completed, I'm going to check occlusion like crazy. So because I was able to wax up the teeth prior and check the occlusion, making sure that there's no discrepancy with the length, you still never know the correct chewing pattern until you get into the patient's mouth. But I try to minimize that, obviously, with my wax ups I do. So these are my 4 go-tos for articulating papers. So anytime I'm doing any anterior teeth, I always start with the 200 micron horseshoe by Bosch. And so what I do is I remove any streaks on anterior teeth. And obviously, because it's thicker, you're going to see the streak. So I remove all that, polish it off. And the good thing is that if your patient's not numb, they can tell you right away how they feel. Then I'll move on to the red and the blue, depending on how well we do with the 200 micron. And I'll check to see if there's any interferences and remove it. So what I'll have the patient do is I'll have them go in a 45-degree angle in the chair and have a chewing pattern. In addition, I'll also cross-reference with lateral excursions and anterior. And lastly, I'm still using shim stock all the time. So I do not want my shim stock to hold on any anterior teeth. So I'm making sure, double making sure that we have complete clearance there. So you don't want any shim stock to hold on the anterior teeth. So you just want to pull it out real easily. And wherever you feel like it's catching, there's your anterior interference, and you want to remove that. So what do I tell the patients after they're done with their composite bonding? I love this picture in the background because I think my biggest pet peeve is watching people bite into apples, and it just scares me every time. I don't think I've ever bitten into an apple like this. But I always say, be careful when you're biting into hard foods. You know, be nice to your teeth. You know, and sometimes when you see people ripping up packets or opening Tabasco with their front teeth or whatever it is, oh, I cringe. So be careful with them. And if you don't polish your margins, well, you could have some staining. This is why I like to go through the series really well with composite, the discs, and going from coarse to super fine. That way you eliminate any unpolished margins, because you will over time see a line, and patients don't like that, or they'll feel it with their fingernail and they'll start to get staining. And what I do is I warn them that you're not able to bleach your teeth or change the shade once we've bonded your teeth. So my protocol with bonding as well is, if we're going to bleach, then let's bleach 1 week ahead, let the teeth rehydrate, and bond a week later. That way we can correctly gauge the shade of the teeth. And if your adjacent teeth get darker, then we always knew what you could go back to, and your bonding will match that subsequently. So with all due respect, now let's bond. I hope I motivated you to get out there and get all your composite tools and composites out and start bonding. And if you guys, of course, have any questions, this is my Instagram account, luminous at 2_smiles, and I'm happy to answer any questions or share whatever it is.
Thank you so much, Dr. Desai. That was a fascinating presentation. A lot to learn there. And we are now open for questions. So I invite our participants today to please go ahead and enter your questions in the Q&A box at the bottom of your screen. Okay, we have a question that has come in from an anonymous attendee. Does the air abrasion do anything but clean the natural tooth structure? Does it remove anything?
Great question. It doesn't remove anything to the point with like a drill would. It removes loose particles, and I always compare it to a nail file. It's almost like, how aggressively are we going to apply the nail file? For me, I really use it just to clean the tooth surface. That way I know I'm working in a clean manner. There's no debris on the tooth. And especially if you're going to do a starburst bevel pattern or whatever it is that you're going to do with the drill, then you can see all that enamel particles. So I just like to keep it clean, but I don't use it to the point where it's aggressive and removing any tooth structure.
Thank you, Dr. Desai. And we have another question that has come in, again, from another anonymous attendee. Maybe I missed it, but what is your light curing protocol, timing, and power?
Oh, okay. That's a good question. So I really like the blue phase light that I use by Ivoclar. And whenever I'm bonding, I'm going to use the 10-second bond. 10 seconds. And then especially when we're doing the lingual putty matrix, what I'll do is I'll bond for 10 seconds. I remove that lingual putty, and I'll do it again from the lingual as well. So from the buccal and from the lingual.
Thank you, Dr. Desai. Okay. We still have time for questions, so I encourage anyone who has one to, go right ahead and enter it into that Q&A chat box at the bottom of your screen.
Well, I guess hopefully I explained it well enough to where nobody has any questions, and I tried to keep it specific and step by step. That way, there's a nice protocol to follow. I follow this to the T every single time. That way it's easy for my assistants, it's easy for me, and we keep it simple.
And it looks like the questions are coming in, Dr. Desai. We have someone else asking here if you recommend patients to get any type of night guard after your bonding.
So because most of my patients are coming in post-Invisalign treatment, what I'll do is after bonding, I'll scan them for their final retainers. Night guard, that's a whole different topic I can touch on another webinar, but it just, you got to see what their occlusal pattern is and see, is a night guard beneficial for them?
Another question that's come in, what brands of composites do you like using?
Ooh, okay. So I use Clinician's Choice Evanes. I use Inspiro, which is a Swedish brand. I use Ivoclar. In addition, I use Voco with Admira. And I've also dabbled with Omnichroma, Tokiyama, 3M. And I have no problem mixing composites. So it's not necessary you have to stick with one brand. You can venture out.
And we have a question here from Dr. Stephen Greco. Any hints on closing the diastema on the case shown with the putty matrix?
Great question, Stephen. So actually, I published that case and it's coming out in the summer. And hopefully you can get it, or if not, you can Instagram message me and I can provide the reference for you. So what I did with that case was, that was a very tricky case because whenever you close diastemas, you always want to make sure that you're giving the equal amount of width for number 8 and number 9. So I do one side first. Obviously, I'm going to do the bigger side just so I can create whichever tooth is a little shorter in width. And then I isolate the adjacent tooth. I'll do a clear mylar technique and a pull through method. But maybe I can do another webinar on that.
Great.
That's a whole technique sensitive subject, but hopefully you can catch the article in the summertime.
Thank you for that. Another question here. What is your decision protocol on choosing direct veneers or indirect ceramic veneers?
Great question. So I keep it really raw and super honest with the patient. So again, once the teeth are into the correct position, I give both options to the patient and I say, here are the pros and cons of composite. Here are the pros and cons of ceramics. You get to choose your pathway because I can do either or. If there's minimal chipping, obviously on anterior teeth, then bonding is the perfect way to go. But like I said, I love to do them on lateral peg laterals, or just even if you see number 7 or 10 is a little twisted and you can contour it to make it look with line angles that, hey, it looks just like the adjacent teeth. It doesn't look like it's off or rotated. So I keep it up to the patients. And obviously ceramics is going to be a little more pricey just because of the lab fee, the time, and so forth. So it's really whatever the patient desires and which way they want to go.
And which ceramic do you prefer for indirect veneers?
So I love Emax, obviously, but I've also used feldspathic in the past. So it just depends on their occlusion. You know, feldspathic is a little more sensitive, so you want to make sure that there's no interference with occlusion, and you get beautiful results with feldspathic. But with Emax, the greater the number of teeth, that's what I'm going to use because it's obviously a little bit stronger and you can get great aesthetic results with a great ceramist.
And this question is from Dr. Frank Matera. What is the brand of the composite gun that you use?
Oh, so the one that I showed that was silver is the Compo Eject by Clinician's Choice. And the other one was by Voco.
Terrific, thank you. We have a few more minutes left. Okay, we have another question here. Do you characterize any posterior restorations with tints or just use the general shade of the composites? If you do tint, do patients ever complain on discoloration?
I laugh because Yes, they will in Newport Beach. And I say that because they want big, bright teeth. Have I done it before? Most definitely. And if I tint, then we're obviously tinting along the grooves with a nice brown tint, but I don't over tint to the point where if the patient sees it, hey, it looks like there's something in there. Did you forget? So I try to keep it very subtle.
Thank you, doctor. And we are coming up a few minutes shy of the hour on the East Coast, 8 p.m. There are any other questions? This would be a good time to get them in these last remaining minutes that we have. On a question just came in on recall, what do you suggest the hygienists do with your composites?
Oh, I tell them treat them like normal. They polish, they scale, and treat them as if they're normal. I always do exams, obviously at hygiene, so I'll double check my composites, make sure there's no staining or any sort of margin, that there's an excess. So, we always check chair side, but during hygiene checks, I'll always double check. But I tell them, hey, just treat it like normal.
Interesting. Thank you, Dr. Desai. Okay, and in these last moments, unless there are any other questions, I would like to take this chance, Dr. Desai, to thank you again for a wonderful presentation this evening. And thank you all for joining us tonight. We did record tonight's webinar and we'll email the recording out sometime in the next week. We would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us, and we look forward to seeing you on future webinars.